Welcome back to Physio Natters, this month in association with Choose Health, and this is session 3. This month I'm delighted to bring you an interview by our own Tyer with Griffin. If you don't know anything about Derek, you're really missing out, and go and find him on social media immediately. You really want to hear from Derek, and so I won't give this any further introduction than it needs. We couldn't cut Derek down enough, so as a bonus content we have provided a session 3A, which includes a case study from Rob's own caseload. This is an absolutely brilliant discussion, and I really recommend checking it out after you listen to this. See you at the end.
Derek, thanks very much for taking the time to come on Physio Natters. You're the third guest that we've had on, and hopefully get to hear a little bit more from you in the future as well. But for today, we're going to focus on some topics that are quite close to your heart, I believe, and that's sensitized pain or widespread pain.
Yeah. Thanks, Rob, for giving me the opportunity to speak. It's a pleasure to have the opportunity to share some of my views with the listeners. So glad to be here.
Great. Excellent stuff, mate. Excellent. So I thought we'd first find out a little bit more about the man himself. So if you'd like to, just tell us a little bit about yourself, please, Derek.
Okay, so currently I'm based full-time in private practice, so I'm working clinically at the present time. Previously, I have done some academic work teaching at the University of Limerick, which is where I did my PhD. So I suppose that's what really got me interested in the whole field of chronic pain. So for my PhD, I looked at people with chronic low back pain and their physical activity profile and the factors that influence their levels of physical activity. So we measured their physical activity using accelerometry, so using objective measures. And I was particularly interested in the different factors across the biopsychosocial domain that influence their levels of physical activity. And through my PhD, I spent a lot of time in pain clinics, so it gave me a great opportunity to hear the very many stories, the complex stories of people presenting with chronic pain problems. And this was, I suppose, the first time that I was given the opportunity into the lives and the worlds that these people live in. And it was a great experience for me because I use a lot of this experience today in my clinical practice.
Excellent. And just out of interest, Derek, where did you come from before you got to PhD level? What route did you take?
Actually, I went straight from my BSc into the PhD. So I was lucky to get funding from the Irish Research Council, which gave me the opportunity to start the PhD immediately after finishing my BSc. So I started within the same year of finishing.
Do you think that made it easier for you to transition into some of these concepts that some people find quite difficult to accept as clinicians?
I think so, because I suppose during my PhD I had the opportunity to do some clinical work as well. So as a new grad out of university, I suppose I was exposed to some of the more modern concepts around pain at a very early stage in my career. And as I said previously, a lot of my early experience was just purely as an observer, so just watching and listening to people with chronic pain, and I think I gained more from that at that early stage than anything else.
And just you don't feel like you've missed out on that junior band 5 Derek Griffin smashing out some traction and grade 3 to 4 mobs for stiffness?
I'm sure there's benefit from working in those kind of settings and working in various settings, but I suppose it's hard for me to answer that question without
to be fair, it was more joking than anything else, Derek. I didn't expect a serious answer from that.
But I am, like I said, I think I was just exposed to the chronic pain world at a very early stage, and that kind of really spurred my interest.
It set the scene for you going forwards then, hasn't it?
Definitely.
Good stuff. So I suppose we'll get on to sort of the meat behind the topic here, and I want to try and get some clinical gems from you then. So with all this experience you've been exposed to,
yep.
When you've got somebody walking in off the street into your private clinic, What are some of the subjective cues you're looking out for which would particularly guide your management or your objective assessment? Sorry, at first.
Yes, I think when we approach the assessment, we need to really approach it with a very open mind, particularly if the patient has been referred from another provider and they often carry diagnoses with them that can, I suppose, bias the clinician's preconceptions about how this patient might present or what exactly is going on. So that's the first thing I'd say, is kind of have a very open mind and assess the patient with, from a very neutral and an objective perspective. So the first thing that I would get most patients to do before I ever meet them is that they will fill out some form of a screening questionnaire. We generally use the Urebro questionnaire, but also a body chart. And I suppose this is an important point, that you can get a lot of information, good information from a body chart, because there is evidence to show that the distribution of the patient's pain, so how many areas they mark on the body chart can often be useful prognostically. So it can give you a glimpse into whether or not you're likely dealing with a more of a localized, peripherally mediated pain state versus a more complex, widespread, centrally mediated pain state. In and of itself, it's not diagnostic, but it can give some useful information. For example, people that report or mark more widespread areas or multiple pain areas on their body charts, we know that the evidence shows that they present with higher levels of sensitivity and higher levels of psychosocial factors and higher levels of disability. So a very simple body chart can be useful at the very, very early stages of that assessment.
That's interesting, because you often find we don't tackle the body chart until the patient's sitting in front of you. So you get them to fill that out in their own time.
Yeah, I think that's important. I think the patient needs to fill it out for validity reasons, but also it gives you a glimpse into what they perceive to be their main problem areas or their main pain areas. So it's their perception that I'm interested in rather than what I interpret from what they're telling me.
And do you get a little glimpse of that before they come into the room, or is that, it's done there and then in front of you with the patient sitting there?
No, they would generally fill that out independently when I'm not there. So before.
Yeah, sorry, but once they've filled that out, do you get a glimpse of that before they sit down in front of you to have a discussion, or do you talk it through with them while they're in front of you?
Yeah, not necessarily immediately. So then I will go on and carry out the full subjective assessment but just use it as part of that assessment.
Okay, that's interesting. So with that, then the widespread crosses or colouring in of that body chart. If somebody doesn't have that widespread colouring in, and they've maybe focused their area of pain in one particular body part, let's say a shoulder, but they are very in depth with how much information they're giving you about that shoulder, would that give you any clues to the same effect as the widespread pain, or would that be something different?
Yeah, I think, again, if they mark more localized pain, then it might be indicative of a more peripherally mediated pain state. But we need to be careful, because I'm looking for a cluster of factors, not one factor on its own. So just because they mark a localized spot on the body chart, this on its own is not diagnostic in any way of the underlying pain mechanism. It's one part of the bigger picture. So it is a clue into the underlying pain mechanism, but in and of itself on its own, it's not the whole picture, and it doesn't give me the other bits of information that I would need to objectively reach a decision. Okay,
I think that's fair. I think we'd all agree with very, very few tests are diagnostic on their own. So then how do you go from there then, Derek, subjectively? What sort of avenues do you explore, or are you very much a sit back and let the patient do the talking and scribble away?
Yeah, I think it is important to let the patient do the talking, but clearly I will guide that conversation depending on what I need to know. So it is important that we allow the patient to air their views and allow them to lead the conversation, but we don't get too off track, and sometimes I'll need to pull them back and ask specific questions. But I don't structure the subjective in any specific way. I allow it as much as I can to flow. and try to get the information that I need in a more conversational way rather than it being too formal. So I suppose the initial thing that I would look for is for them just to describe their symptoms to me, what they perceive to be their main symptoms and or other or main pain problems and their other symptoms, and particularly the onset of the onset of the symptoms and the context that surrounded the onset, because the context is as important as the symptoms themselves, because again it gives you a glimpse into what their life was like at the time that they developed their main problem. So that it is important to not just identify their symptoms, but when these symptoms began and what was going on in their lives and the context around the onset of their symptoms.
And how deep do you pry on the first session, Derek?
Generally, I have the luxury of having quite a bit of time with patients, so generally at least an hour I would have for an initial assessment. Sometimes I would go over to an hour and a half. So it depends on the patient, but generally I try to get as much information as I can in that initial assessment. I like to kind of have the different pieces of the jigsaw puzzle, so to speak, or have a good overall background history so I can piece together the puzzle and at least in my head have a rational account as to their pain state and what factors might have both led to it and factors that are currently involved in driving their pain.
So some key features that I think I'm aware of with regards to pain would be, say for example, nighttime pain. Mm-hmm. Is there any sort of little handy tips that you've got that could help some people listening differentiate nighttime pain in how sort of important some of that information is?
So I suppose this links in with their sleep patterns as well. Mm-hmm. Is their pain sufficient? Do they wake with pain, or are they waking up for other reasons? And is the pain causing them to wake up, or is it when they move or turn that they get pain? So is the pain more movement related at night, or again has it more of a mind of its own where
yeah, that's exactly the sort of thing that
less mechanical.
I would potentially ask somebody. I just wondered how much of that is valuable in terms of your subjective assessment when you believe somebody has some high centrally driven pain state.
I suppose in and of itself it wouldn't necessarily lead me to think that night pain on its own is a characteristic of central sensitization per se, because we can have some more peripherally mediated pain states where nighttime pain is a problem as well. So again, I suppose it's one feature of many. If the other features fit, then it's more likely to be relevant. But I'm particularly interested in how that nighttime pain is influencing things like their sleep, and whether or not there is a mechanical basis to that, or whether there's a movement relationship to their night pain, or whether it's more of a mind of its own. For example, in more kind of typical neuropathic pain states, we know that pain is often worse at nighttime. And that, again, it might be relevant in some cases that it may guide me towards a particular pain mechanism in those cases.
And is there anything else, if we were to sort of go through our university undergraduate level teaching of a subjective assessment, we've covered the mechanism of onset, we've covered a diurnal pattern to a degree, included in the subjective history would be past medical history, family history, social status at this time. Is there anything else that you have a particular interest in that would give you bigger clues?
Yeah, I suppose and again it depends on whether or not the subjective is leading me to believe that we're dealing with more of a widespread centrally mediated pain problem versus a peripherally mediated problem. My questioning might change a little bit, but typical things that I would be very interested in is any early life events. So we know that early life events are predisposing factors for somebody to develop chronic pain later in life. So again, I'd be interested in any trauma, be it physical, psychosocial, during during their childhood or during adolescence that may have predisposed to the development of some of these factors. So early life events are important as part of that assessment.
How is that question received sometimes, Derek?
Yeah, you do need to be careful of it, but I suppose my own opinion on it is that it is an important question that we need to ask, and it's, to me, there can be a lot of stigma around issues around mental health or things that, particularly if we're dealing with any form of psychological trauma. But in an attempt to get rid of that type of stigma, I don't see it really as any different than asking somebody if they have diabetes or if they have a history of, cardiovascular disease. It's to me, it's not different. Okay, the patient may, it depends on their perception of it. But as clinicians, I think we need to be confident in asking some of these questions at a later stage when it comes to explaining pain. I suppose we need to reason with them why I'm asking these questions. So
Yeah, that would be my next question. Is confidence in the delivery enough? Or do you have to have a particular method of framing that question?
I think you do need to be confident, but I think you need to be clear with the patient why you're asking these questions. And this comes back to, things like explaining pain and things like that. So I wouldn't necessarily wait till the very end to explain all that to them. While I'm asking the questions, I might use that question as a way into talking about these kind of factors and how they influence pain. So again, it can be difficult. I'm not saying it's easy, and
definitely not easy.
Yeah, in some cases you may get a negative reaction, and again, depending on how the subjective is going, I think you get a feel for whether or not it's an appropriate time to ask a specific question. You can get a general perception of how well the patient is taking things on board. And depending on that, I will ask a particular question or not. So again, it's hard for me to give you a concrete answer.
I imagine without examples and having a patient in front of you, it is difficult. So say for example we've got this suspicion that someone's got a centrally driven or possibly some features of a peripherally driven pain state from the subjective. Where do you go then, Derek? When you enter into the objective assessment, what are these key differentiating features that you sort of look for? Yeah,
so I suppose just briefly going back into the subjective before I talk about the objective assessment. The other things that I would clearly look for. So we discussed around, is it localized versus more widespread? That can give you a good indication of what you're dealing with. But also things like hypersensitivity to features other than pain, that would be features of central sensitization. So things like irritable bowel symptoms, nausea, restless leg syndrome, jaw pain, headaches, all these other features that go with central sensitization. So I would ask these in the subjective, because in a pain state that's dominated by central sensitization, it's very common that you will find some of these extra features, and they can give you a really good insight into the primary pain mechanism. And then clearly other things around their illness perception. So if they come with a diagnosis, or I want to know what they understand by that diagnosis, what they believe their pain is telling them, what their pain means. Is it what's causing their pain? So those kind of things are important. The effect on their social life. So do they perceive themselves as being lonely? Are they fulfilling social roles? Has there been any threat to their identity as a person, or as a mother, or as a father, or whatever their roles might be? Things.
And are you thinking as a result of the pain, or something that's predisposed them to having this pain?
Yeah, again, both. So again, that's where you need to go in with a very open mind. So I'm interested in what they're like at the moment, and again, having a good discussion with them around whether that's as a result of their pain, or has that always been an issue, or has it been an issue prior to the onset their pain. Family.
It's not straightforward, is it? Because we've got people who have identity issues and mood problems who don't have pain.
Yeah.
But we never see those guys because as physios, people come to us in pain.
Exactly. So again, it's again just one piece of that puzzle, and it may or may not be a part of their current problems. But again, it's important to understand how the pain is impacting on their life, and whether there are factors in their lifestyle that may be impacting on the pain. So these relationships are often bidirectional in nature. Things like, you know, their previous treatments and their experiences from that, and how that has changed their expectations of how well they're likely to do with intervention. Comorbidity. So again, it can give me a good insight into the person's overall health and well-being. And again, these are important points to note going forward, to see whether or not a lot of these factors are amenable to change as part of an intervention. So at the end of the subjective, in my head, I like to have at least some form of a clear picture as to what factors may have, if there was any predisposing factors in their early life prior to the onset of pain, what factors were involved in triggering the pain, and if there was a context surrounding that, and then how the pain has affected various aspects of their life, and whether or not we can change a lot of these things.
Excellent. So it's a bit of a juggling act in your head, that sort of dynamic clinical reasoning while moving forwards with that patient in front of you. So if we do then address some of these objective features that I think what I certainly would like to get out of this would be, you know, I have someone in front of me, they may have neck pain with arm pain or back pain with leg pain, and you know, from a safety perspective, I'm going to do a hard neurological assessment including reflexes, myotomes, dermatomes, but all that's really telling me is that, do they have weakness, do they have sensory deficit, do they have reflex deficit? What are you looking for if we are maybe going down that line of centrally mediated pain?
Yeah, so again, the objective should very much be seen as an extension of the subjective, and they're not separate. I don't really consider them as being that distinct, but
yeah,
what I will look for objectively will again depend on the subjective. So if from the subjective I get the impression that we're dealing with more of a non-specific, non-mechanical pain disorder, then when it comes to looking at, say, movement behaviours, I'm much more interested in their gross movement behaviours rather than anything too specific. Whereas if it's somebody with a chronic low back pain problem and they're quite specific with movements that aggravate them and ease them, then I might focus in on those specific movements in the objective. So again, listening in the subjective will guide what kind of things that I will look for objectively. But general things, looking at body language, looking at how people move habitually, how they get off the chair, how they get onto the chair. So again, just a very general and broad assessment of their overall movement would be something that I would look for. If again we're dealing with more of a centrally mediated pain problem, pain on palpation, so I think palpation can be useful in determining any kind of widespread sensitivity. So looking at the pressure pain thresholds in various parts of the body. So a general pressure pain threshold examination of the upper limb and the lower limb to see if there are multiple areas of sensitivity, or is it again localized to the to one area. And just looking at general things like the patient's willingness to move, you know, their confidence with movement, any grimacing, any pain behaviours, any safety behaviours, and again just keeping that big picture in mind before I look at anything more specific.
So if I could just maybe jump in on that palpation threshold thing, if we're talking about the difference between sort of primary site hyperalgesia versus more widespread secondary hyperalgesia.
Yeah.
What does that tell you? I mean, because it may be that people out there might agree that when you've got someone with lower back pain and they don't have these widespread tenderness to touch, but when you do light light touch on their area of pain, their sensitivity's through the roof. What does that tell you, Derek?
So again, similar to looking at their subjective reports of their pain distribution, if someone is presenting with more widespread tenderness on palpation, that again to me is indicative of a more involvement of central mechanisms involved in their pain state. Whereas if it's looking like it's a more localized to the area that they mark on the body chart, and when it comes to the palpation, that you find that the tenderness is in and around this area and localized to that area, then again that would lead me more towards peripherally mediated.
And would you consider peripheral sensitization if you thought that their pain that they were expressing was higher or disproportionate to the level of stimulus? So if it was just lower back pain and you pressed their back and you had to peel them off the ceiling.
Yeah, so again, I suppose one of the features of central sensitization is just that where the pain response is often out of proportion to the input or to the activity that they're doing. But I suppose this comes back to the fact that sensitization exists on a continuum, and in reality we're dealing with the one nervous system. So I suppose the peripheral central divide is in some ways a very reductionist approach, and maybe in some cases it can become problematic because we end up treating a pain mechanism rather than the factors that we've identified as part of the assessment that might be contributing to that sensitization, be it peripheral sensitization and or central sensitization. So it doesn't mean because the pain is localized that there is no element of central sensitization, but it probably would suggest that there may be more of an issue in the tissue rather than a more widespread sensitivity problem per se. But again, on its own, palpation is part of the bigger assessment, and it's one tool that gives an idea into the bigger picture.
Do you find yourself doing anything more flashy? I would say, the 2-point discrimination, the graphesthesia type assessments. But do you find that they're useful clinically, or do you think that you've got more important things to cover?
Yeah, to be honest, I don't use any of the 2-point discrimination. I sometimes look at someone's laterality, so using the recognised program online, and again that can give you another glimpse into what you might be dealing with. So if there were changes there, again we know that's associated with different changes in the central nervous system, cortical changes regarding that somatosensory areas. So again, that can provide a clue that we are dealing with more widespread changes throughout the nervous system rather than just dealing with the with an issue in the tissue per se. But again, I don't use it on a routine basis, just if and when I feel it's necessary.
So if we're talking about certain things that we can apply, and I did say I was going to try and pin you into a corner with one question. Is there a scenario or a situation where Derek Griffin would find himself laying hands upon someone and providing some interventional treatment to them passively? Can you see a place for that?
It's a good question, and I know people will probably think that I do come down heavy in manual therapy. And look, I suppose I do see a lot of people with more widespread, complex chronic pain problems. So I suppose like any clinician, we all have our biases against certain things, and because the type of patient that I tend to see generally are not that amenable to manual therapy, or from a clinical perspective, after I assess them, I don't feel that may be the most appropriate or useful intervention. But in the more broader scheme of things, I think it does have a role, but we need to be very careful with it. I'm not as convinced as others that it. I've been known to kind of go against this whole idea of it providing a window of opportunity. I'm not really sure that there's a huge amount of evidence to suggest that it does. There is evidence to suggest that there can be a temporary change in pain, but again, I think it's a bit of an extrapolation to assume that because we get a short-term pain a change in pain, that automatically means that our active interventions are going to be more successful, or we're going to be able to implement them a little bit easier. So I think we just need to be careful about what the evidence does and doesn't tell us regarding, any outcomes apart from a very short-term change in pain. But use of manual therapy, particularly in terms of the assessment, I'm not a particular advocate of more accessory mobilizations, particularly for the group that I see. But things like just passive movements, general passive physiological movements, can be quite useful to kind of facilitate or to encourage somebody to move, or to get an idea in the assessment of how willing somebody is to move a particular body part or area. So I think passive movements, again, can have a role to play. But again, I'm always thinking bigger picture. Can I use this to facilitate or encourage somebody to move in a more relaxed way? And from an assessment perspective, can it give me an idea of how willing they are actually to move that particular body part? So kind of passive physiological movements where there is actual movement of the body part rather than just poking on a joint, to me, will serve a bigger purpose.
Something that they can mimic later on rather than accessory stuff that they can't achieve themselves.
Perfect, because they can associate with that. And graded exposure is highly context specific. So again, it more replicates normal human movement rather than just poking on a sore spot, which in and of itself is a meaningless movement, although it might change pain in the short term. So if passive movement changes pain for whatever reason it does through modulation of the central nervous system, then we can achieve that in many different ways, manually and passively, rather than necessarily in a just poking on a sore spot.
No, I think that's fair, and I'd like to think that that's something that makes sense more than just physiologically. It's more common sense. If someone won't lift their arm up, if they're quite happy for you to lift their arm up and they can see that can be achieved, they may be then more willing to give that a go themselves. And I suppose that kind of brings us on to a discussion I know you and I have had in the past about the literature you're quite interested in at the moment about detraining certain phobias, and that the conflict of expectation and outcome has to be high in order to create an effective change. And I suppose you could use this as an example that the physiological movement may have had an expected pain response, and in this instance hasn't. So therefore, that's given that patient a nice little buy-in, and they can go forwards from there.
Exactly.
Would you say that's a fair example of what you were saying?
And again, that comes back, I suppose, to one of the key principles of any form of exposure-based intervention is the specificity. So that the type of exposure intervention that we do, or the outcome that we'll get from it, will be entirely dependent on the context that we've done that treatment in. So again, to use that example, before we might do the movement with the patient, again, their expectation might be that this is going to be quite painful, or it's going to cause a lot of pain. And if and hopefully, by doing that in some form of a different way, either passively or otherwise, that creates a mismatch between their expectation and the actual outcome, then that's a powerful learning stimulus from the patient, and they're more likely to persist with that behaviour.
I think that's a great point to end on, Derek. I think there's definitely more to discuss here, but not for this sort of format. I think we maybe need to get you back on at a later stage and explore some other things. It'd be great if you have any key texts that you think are interesting, if you could ping me over a link and see if we can get that on the Google Drive, so people can access them at their own leisure. But yeah, any sort of events you're talking about, any courses that you're running at the moment, Derek, or is that pretty much you for this calendar year, focusing on marathon training?
Yeah, nothing planned at the moment. So I'm currently in the middle of marathon training, and like I said, I'm quite busy working clinically, and I do see quite a large percentage of my clinical work is managing or helping people with persistent pain state. So I haven't gone on the course circuit yet or anything. Nothing in the pipeline. There's just one or two local events for some local physiotherapy groups that I'll be talking at later this year. But nothing beyond that.
Brilliant. Be sure to keep us posted.
Great, and thanks again, Rob, for just giving me the opportunity. I hope the listeners enjoy it.
Great. Well, I certainly have, if nobody else has.
Well, there you go. I really enjoyed that discussion between Rob and Derek, and I hope you did too. I certainly learnt a few things, and I'll be implementing them in my clinic coming up soon. If you haven't already, check out the case study with Derek and Rob as session 3A. That's a really interesting chat also. Check Derek out on social media. He is at Derek Griffin 86. Rob is at Combat Sports Phys, and the Physio Natters podcast tweeting out of at TPM podcast. Don't forget, we have now 28 sessions of the Physio Natters podcast, the most recent of which has given us more feedback than we have ever had before on the show. Good, bad, indifferent, rude, you name it, we've had it. So keep on listening, and we'll see you next month for more Physio Natters.